Hi, my name is Michael, and this is the third part of the ENT teaching series with 10-Minute Medicine. And today we'll be talking about sore throats. So by the end of this talk, I hope you'll be able to recognize the differentials for a sore throat, call the management of tonsillitis and the scoring systems we may use to help guide management as well, and to recognize and identify the complications of tonsillitis. So to start with, I just want you to be able to pause this video and name 3 differentials for a sore throat. So sore throats can be caused by many different things, and I've tried to name at least a few of them on this slide. So I try to categorize them into infectious and non-infectious causes. The most common infectious cause of sore throats is viral causes. So that would leave you with sort of common colds, influenza, COVID-19, and also EBV, Epstein-Barr virus, causing infectious mononucleosis. And this is an important differential to have when you're assessing someone for tonsillitis. So within bacterial causes, the most common bacterial cause is group A streptococcus, which can commonly cause tonsillitis and also can lead to things like peritonsillar abscesses, retropharyngeal abscesses, and you should also consider things like epiglottitis as well in sort of younger children commonly. Non-infectious causes can include inflammatory causes, malignant causes, and also things like hay fever and trauma can also cause sore throat. So I want you to imagine that you're the F2 in ED and you're seeing John, who is a 20-year-old gentleman, presenting with a 4-day history of progressively worsening sore throat. He describes adynophagia, so painful swallowing, and he's struggling to keep food and fluids down. And he's really had very minimal intake of fluids over the last 2 days. He reports fevers, chills, feeling generally unwell, and he's had no recent cough. So on examination, he's pyrexial, so he's got a temperature of 38.5. He shows no signs of respiratory distress, no sort of drooling or hoarse voice, which in the acute situation could make you worried a bit about the larynx and inflammation of that, such as laryngitis or epiglottitis. And his chest is clear as well. He has no sort of stride or airway compromise currently. In terms of fluid status, he appears slightly underfilled. He's got dry mucous membranes, and his cap refill slightly prolonged at 4 seconds. You look inside his mouth. He has no issues opening his mouth, so as in he's got no trismus. It's another word for it. And on the right, you see a photo of his oral cavity. So, as you can see, you have sort of the anterior arches or the palatoglossus arch here, and behind it you have the tonsil, and on both sides they appear erythematous and swollen, and you can also see that's the case for the uvula and also the pharynx as well. On the tonsils, there's bilateral tonsillar swelling with tonsillar exudate as well, you can see on both sides. He, on examination of his neck as well, you note there's bilateral cervical lymphadenopathy, and he's able to move his neck without any issues, and there's no neck stiffness. And that's just important to have a look at as well if you're worried about sort of potential abscesses around the pharynx that might cause stiffness or pain when moving your neck. I guess if this patient was to have a normal examination of his oral cavity, but he has sort of red flag symptoms, so he looks very unwell, he has changes in his voice, difficulty swallowing, then it might also grant further investigation to have a look, potentially with further scopes, to have a look at his pharynx and whether there's any sort of collections deeper down. So On investigation, you've done some bloods, which is great. You see that his white cells are raised, and you also notice his neutrophils are raised with a normal lymphocytes. So that's important because having that white cell differential, seeing that the neutrophils are higher, and you have normal lymphocytes may point more towards a bacterial infection. He's also got an AKI1, so he's dehydrated, probably because of his low oral intake. His LFTs are normal, and his CRP is raised as well. You've done the COVID and flu, and that's negative, and you've taken some swabs, and that's pending. You've also sent off a monospot test, which is for testing for infectious mononucleosis. It can be quite difficult sometimes to differentiate between infectious mononucleosis and viral causes of tonsillitis as well as bacterial causes. The white cells help, but monospot tests is a blood test that will also help guide therapy. So we think this could be a bacterial cause given his high neutrophils. What scoring system would we help guide management? As you probably have guessed, the Centaur score is what we use. And this will help differentiate between whether we should be giving antibiotics or not in tonsillitis. So it's important to note that 70% of tonsillitis is viral, whilst 30% are bacterial. We use Centaur scoring, which includes whether they have a fever, whether they have tonsillar exudate, whether they don't have a cough, and whether they have anterior cervical lymphadenopathy, and also considers their age as well. So in this case, I just want you to quickly pause the video and have a think about how this patient would score. So this patient would score for a fever. It would also score for tonsillar exudate, as you saw on examination of the oral cavity. He doesn't have a cough, and he's got cervical lymphadenopathy. So he's got a Centaur score of 4. And that indicates on the left-hand side, you can see a risk of 32 to 56% of isolating streptococcus. And therefore, you should consider an immediate or backup antibiotic prescription. So for this patient, if they had only a Centaur score of 0 or 2, you might consider, you might not give antibiotics in this case and reassure the patient, safety netting them for any sort of worsening symptoms or if they don't improve after a week. So the plan for this patient, I think, would be to admit. They have poor oral intake, they've got an AKI as well, and you'd want to give them analgesia, IV fluids, since they're unable to take anything orally, and with an aim to switch to oral fluids when they're able to. You'd give them sort of antibiotics according to trust policy and according to their allergies, and often this treatment can help reduce inflammation and help them feeling better and help them eat and drink sooner. You'd also want to chase them on the spot test as well. Say in sort of a parallel universe, John hasn't seen a doctor but presents weeks later with the same issues. Instead, he presents with fevers, unilateral sore throat, trismus, so difficulty opening the jaw, and a hot potato voice. I guess firstly, what do you think this could be given the examination? Given the examination you can see below. So you can see that his uvula is deviated, and there's sort of peritonsillar swelling as well on the right side of the oral cavity. Given its unilateral presentation as well, and its trismus, these are all sort of signs of a peritonsillar abscess, or otherwise known as a quinces. So the management would be the same as a bacterial tonsillitis, except that they would need to be admitted for aspiration and drainage. So either they can sort of aspirate it with a needle, which we won't go into details as to how they do that, and that you can see on the right hand side. Or you can perform an incision and drainage with a small scalpel as well on the left hand side. So complications of tonsillitis, two of them which I think are important to know about are one, a Quincy's, which we've just gone through, and also a deep neck space infection. So things like, the tonsillitis or bacterial tonsillitis can track down into the retropharyngeal or the parapharyngeal spaces as well. And there are many causes for a deep neck and space infection. One of them is tonsillitis, but they can also be caused by dental infections, skin infections, and neck trauma as well. And you can see in the bottom right photo that sometimes on examination, you'll be able to see a swelling in the neck. And with that swelling, they'll have difficulties moving their neck. They'll have stiffness. They have a very sore throat. Sometimes they might have airway compromise as well with stridor or drooling. They'll be pyrexial, and they'll be very unwell as well, usually. You can see in the top right that you are able to see some swelling in at the back of the pharynx. However, this is not always visible when examining the oral cavity. And so really with these patients, as with every patient, sort of an A2E assessment, so informing your ENT reg and gaining some IV access, so getting bloods off the patients, giving them fluids if they're having difficulty swallowing, and giving antibiotics as well. They'll probably need a CT of their neck and chest with contrast, and I think it'd be a good idea to keep them nil by mouth, as they might need surgery to help drain that abscess too.